Hello everyone, welcome to our new video. In today's video, I'll be discussing chapter 13, 14, and 15. So stay tuned guys because your chapter 15 is a very important guideline in your actual exam because they will going to ask at least 2 to 3 questions. It might not be on the ICD section but they will going to ask in the CPT sections about your genitourinary and pregnancy. So it's very important guys to understand this chapter because your chapter 15 has a unique guideline. So we will be discussing also in the chapter 13 and chapter 14, but those are quite short guidelines. So that's why I'm highlighting chapter 15 because this is a long guideline and it's very unique and they will going definitely to ask questions about these chapters. It's very important to understand your ICD-10, chapters 13, 14, and 15, 2020 guidelines. So stay tuned. Let's start first with your chapter 13. So your chapter 13 is your diseases of the musculoskeletal system and the connective tissues. We will not going to discuss only about the bone. We will not going to discuss about the muscle only, but we will going to discuss the muscular and the skeletal and even the connective tissues, like your. We may also tackle about the joints here. So let's start with your chapter 13. Now, before moving on, let's start first with a common example of the codes that we may see in your chapter 13. As you can see from code M00 or category M00 to your category M99. I have an example here for code examples. You have your M17.10 unilateral primary osteoarthritis unspecified knee. M17.11 unilateral primary osteoarthritis right knee. M17.12 unilateral primary osteoarthritis left knee. So what you can see in the examples that I have is it is being divided based on the location. We're talking about the knee. So we may the codes are divided based on your anatomical location or the site, also known as the site. And as you can see also the differences of the code is the laterality. So when you say laterality, is it left, right? So if there's no specification at all, we may end up using unspecified. But sometimes we also need to use the bilateral and the unilateral because remember we have you have two parts like your knee, your arms, right, your joints like in your elbow like that. So codes are divided based on the anatomy or the anatomical location and the laterality. So this is in connection to your first guideline, which is a site and laterality. So most of the codes from chapters 13 have site and laterality designations. So meaning most of the codes that you may encounter in your chapter 13, you need to know the specific site or the specific anatomical location and the laterality if it's left, right, or it's an unspecified. The site represents the bone. When we are talking about the anatomy or the site, we're talking about the bone, the joint, or the muscle involved. For some condition where more than one bone or one joint or more than one muscle is usually involved, such as osteoarthritis, there are multiple sites or there is a multiple sites code available. So what should you do if that is more than one or there's a multiple sites that being included? Because remember, it's divided based on site and laterality. So the guideline is for categories where no multiple site code is provided and or more than one bone, one joint, or muscle is involved, multiple codes should be used to indicate the different sites involved, meaning you need to code them all. Because remember, there is a specific code per site. So you need to code everything. If it's a multiple sites, code them everything. Now the question is, what should be the first listed code? It depends. Okay? Because there's no guideline about the first listed, but you need to code them all. Okay, that is the first guideline. Now here is some common scenario or unique scenario that you may encounter in your coding work. Like for certain conditions, like the bone may be affected at the upper or at the lower end of the bone. Like for example, we're talking about your humerus. Okay? We're talking about your humerus. So the end is in the elbow and in the shoulder. The upper end is in the shoulder, right? And the lower end is in the elbow. Okay? Now, as you can see, if it's in the end of a long bone, it is connected by a joint. So sometimes, if the end part of the bone is affected, the joint may also be affected, correct? Because right after the end of that long bone is the joint, correct? So though the portion of the bone is affected, because that we're talking about the end of the bone, and also since the end of the bone, there's the joint, okay, though the portion of the bone affected may be at the joint, the site designation will always be the bone and not the joint. So in this case, like bone versus joint, bone always wins. Okay? That is your guideline. Next, letter B of your chapter 13. Guys, this is a common question in the exam. Like, if there's a fracture, remember there are there are two different reasons why the patient may suffer a fracture. Okay? When you go to your alphabetic index, when you go to the word fracture, you need to identify if it's traumatic or pathologic. Correct? You need to go through your alphabetic index, go to your letter F, check for fracture. As you can see there are two different things that you need to consider. Is it traumatic or is it pathologic? In this guideline, we're talking about acute traumatic. Obviously, we're talking about traumatic versus chronic or recurrent. That is your pathologic. Okay? Now, when you say acute traumatic, like this is your vehicular accidents, fall in the bed or fall in the stairs like that, and the patient or suffered, your injury or traumatic fractures. So when we are talking about injury or traumatic fractures, we will code those cases later on in your chapter 19, which is your injury or your acute traumatic fracture. Now, your chronic or recurrent musculoskeletal condition is coded under your chapter 13. So, in the exam, like when you see a scenario that they're talking about fracture, and when you see the options, like two options starts with letter M, and two options starts with letter S. Because your traumatic or acute traumatic fracture is coded under your category as in the S codes in your chapter 19, which we will discuss in the next video. For this one, your chapter 13, it is your M. So, if you see like there are options like that, like A and B starts with M, and C and D starts with letter S. Now, here's the first thing you need to think. Are we talking about the acute or are we talking about the chronic one? Now, if you found out that we're talking about the chronic, you can eliminate the first two. Correct? Or you can eliminate the second and the third and the fourth choices. Like, for example, if those are S codes. Correct? So, many musculoskeletal conditions are a result of a previous injury or trauma, the site, or a recurrent condition. So, that's why when you say recurrent, there's an initial and there's a recurrence of that condition. Now, if it's a recurrent, it's coded under your chapter 13. It's M. Bone, joint, or muscle conditions that are a result of a healed injury are usually found in your chapter 13. Here, please highlight this one. Recurrent bone, joint, or muscle conditions are also usually found in your chapter 13. Okay? And any current acute injury should be coded to your appropriate injury code for your chapter 19. So chronic or recurrent conditions should be generally be coded in your code from chapter 13. If it's difficult for you guys to determine from documentation in the record which code is best to describe the condition, you always need to query your providers. Okay? coding of pathologic fractures. Since we're talking about chapter 13, we're talking about pathologic. When you say pathologic, the patient suffered a fracture due to an underlying condition. Meaning, it happens, the fracture happens due to a certain conditions, which we're going to tackle later on about your osteoporosis. Because that is a common reason why a patient may have a pathologic fractures. Or the common examples, the patient may have remember when we discussed your neoplasm? Okay, in your chapter 2, the patient may, if there's a cancer of the bone, the patient may suffer pathologic fractures due to the cancer. So, meaning that fracture is always due to underlying condition. It's not about your accident, it's not about an injury like that, because that should be coded in acute or in the injury codes in your chapter 19. Now, as you can see, keep in mind for fracture, there's a special guideline with your 7th character. Remember your 7th character, that the very common 7 characters are your 7th character A, remember, for initial, 7th character D for subsequent, correct? And 7th character S is for your sequela. For your chapter 13, there's an additional code, there's an additional 7 characters that we will going to use. Okay, so let's start first for the common 7th character A. I just need to reiterate what is your 7th character A is for use as long as the patient is receiving an active treatment. So every time I see the word 7th character A, the common word that is associated with your 7th character A is always active treatment, meaning there's still an ongoing treatment about your fracture. So while the patient may be seen by a new or different provider over the course of a treatment for a pathologic fracture, assignment of 7th character is based on whether the patient is still undergoing active treatment. Even if the second, third visit already, but as long as there's still an ongoing treatment, you will going to use your active treatment 7th character A. Okay, whether by seeing the patient for the first time. 7th character D is to be used for encounters after the patient has completed active treatment for the fracture as receiving routine care, for fracture during the healing or recovery phase. For 7th character A, we're talking about the active treatment. This is still ongoing. 7th character D, we're talking about the healing phase or already the recovery phase. Now, the common example that you may going to use your 7th character D is, for example, the patient came in for cast change. Okay, because the active treatment is already done or already completed. Now the patient just going to have your receiving a routine care. Like for example, there is your cast change. Okay. The last one is 7th character S, supposedly sequela, but I'll just going to discuss first for the other 7 characters listed under each subcategory in the tabular list are to be used for subsequent encounters when we are talking about treatment or problems associated with healing, such as malunions, non-unions, and sequela. Meaning the other 7 character codes, we are talking about your subsequent encounters for treatment of problems associated with healing, your such as malunions, non-unions, and sequela. Okay, go to your code, category code, subcategory, because this is already a 4 characters. M84.4 to your M84.6. Okay, go ahead and check your book, M84.4 and M84 up to your M84.6. So before that, you have your other 7 character options there. So let's start with the first one. If you can see the 7 character G, that is your subsequent encounter for fracture, please highlight delayed healing. If there's a delay in the healing, it should be your 7 character G, and this is your subsequent encounter already. We're talking about the treatment recovery phase or the healing phase. 7 character K, we're talking about non-union. 7 character P, that is your malunion. And your 7 character S is your sequela. Now, what is the difference between your malunion and non-union? Obviously, when you say non-union, there's a healing in both ends of the fracture, but the bone doesn't connect at all. It's no longer connected. They never connected at all. So that's why, guys, it's very important to be accurate in your casting like that. Remember that? Or your suspensions like that. So immobilization is very important. So that's why you always need to consult your provider regarding fractures, because it's very important that the healing may happen correctly. For malunion, we're talking about the bone connected, but the bone that doesn't connect properly. Okay, did not connect properly. Although they are connected, but for some reason they were not connected properly. Or correct? So those are additional 7 character. We have 7 character G, K, P, and S. Okay? So care for complication of surgical treatment for fracture repairs during healing or recovery phase should always be coded under your complication codes. Guys, they will going to specify this is a complication. So remember, if it's a complication, you always need to use your T codes, as I always mention that in my previous videos that I have. Okay, now let's start with, I think, the last topic with your chapter 13 is your osteoporosis. Now, these are common questions as well in the exam, and you may also encounter this in your actual coding where I encounter a lot of this, your osteoporosis. Okay, your osteoporosis, guys, as a definition, it's also in your book, is a systemic condition, meaning that all bones of the musculoskeletal system are affected, because it's from the keyword systemic. Okay, so all of your musculoskeletal system is affected from cephalocaudal, from head to toe. So since it is a systemic, therefore site is not a component of the codes under category M81, osteoporosis without current pathologic fractures. And you have some codes, the sites codes under M80, osteoporosis with current pathologic fracture. Identify the site of the fracture, not the osteoporosis. Still, okay, we have two categories that we're going to discuss with your osteoporosis. You have your M81, osteoporosis without current. There's no ongoing. When I say current, there's an existing fracture right now. Now, for this without current, there's no existing fracture right now. For category M80, there's an existing fracture. So as I mentioned a while ago that for without, of course, we no longer need to put in the site, because we only need the site if there's a specific site of the fracture. But for your M80, you need to identify the site of the fracture for some reason, not the osteoporosis, because it is also it's already assumed that all body parts suffered osteoporosis. Okay, so that is just the reminder for osteoporosis. Now let's start within. I will discuss M81 and M80. Let's start first with your category M81. Osteoporosis without current pathologic fracture. When you say without current, there's no existing fracture right now. There's no existing treatment for a certain fracture right now. Okay, but a patient may suffer a fracture before, like excuse me, like the patient may suffer the osteoporosis before, and then the fracture healed already. Okay, now even if the patient suffered a fracture before, if that fracture is already healed, that is not considered current, correct? Because that is already past. Your past is different from your current, correct? Just like you're having your relationship. Alright, so your without current pathologic fracture is used for the patient with osteoporosis who do not currently have a pathologic fracture due to your osteoporosis, even if they have had a fracture in the past. So what if? So what should you do if it is specifically documented in the medical record that the patient also suffered a pathologic fracture before that is already healed? What should I do? So for patient with a history of osteoporosis, fracture status code Z87.310, personal history of healed osteoporosis, fracture should follow the code from M81. Just to capture the whole thing, just to specify the whole scenario or what happened to the patient, you may still use M81 and Z87.30310 for the status code for the healed osteoporosis. Guys, this is different from the next category, which is your M80, because for category M80, osteoporosis with current pathologic fracture is for patients who have a current pathologic fracture at the time of encounter. Okay, it's obvious, like, but for M80, we need to identify the site of the fracture because we need to be very specific what site of fracture is being the site of the fracture is important in order to specify what is the actual anatomical location or the site. A code from category M80, not a traumatic fracture code, should be used for any patient with known osteoporosis, even if they suffer a fracture. If the patient has a known osteoporosis and they suffer the fracture, like if the patient had a minor fall or trauma, and if that fall or trauma would not usually break a normal healthy bone, that is still considered, you will still need to code your M80. So the common example here, like for example, because we are talking already about minor fall or trauma. If it's a minor fall or trauma, remember, if it's a fall or if it's a trauma, that should be coded in your chapter 19, correct? Because it's a fall or trauma or traumatic injury or traumatic fracture. But for your M80, we're just talking about when to use M80. Like, if the patient already had or already have this diagnosis like osteoporosis already, and the patient suffered a fracture due to a minor fall or trauma, which is for a normal patient. Like, if you don't have the osteoporosis, okay, if you don't have the osteoporosis, you may not suffer fracture for just a small minor fall or trauma, correct? It's not common that you may suffer right away a fracture if it's just a minor fall or minor trauma, correct? But for patient with osteoporosis who suffered a fracture due to a minor fall or trauma, which is not usually happen to a normal healthy bone, you still need to code it in your M80, even if it's technically the cause is trauma or minor fall, because the patients already have your osteoporosis. Is that confuse you guys? Because I am also confused as well this guideline sometimes, because the bottom line here is the patient already have osteoporosis, and it's very common that they may suffer fracture already, even if it's just a minor fall or trauma, which does not usually happen if you have a healthy bone. Okay, that is your guideline in your chapter 13. Okay, so yes, we're done with chapter 13. Now let's move on to your chapter 14, diseases of the genitourinary system. This is a very short guideline, so I might focus more on the chapter 15. Now for your chapter 14, you will just going to see the guideline about your stages of your chronic kidney disease, which I also discussed in your chapter 9. Remember when we discussed hypertension with chronic kidney disease, you always need to specify the stage of your chronic kidney disease. So here are some examples. Here are the stages of your CKD. We have your stage 1 is also known as N18.1. Stage 2 is also known as N18.2, is also known as your mild. Please highlight that one because sometimes they will going to put in the word mild and they will not going to put in the stage like 2. Okay? They will highlight the word mild. Stage 3 if it's a moderate CKD. Stage 4 if it's your severe CKD. Stage 5 is for, sorry, there's no other name. Okay? For N18.5 and N18.1. Okay? So they will always put in the stage, like they need to put it, you write the word stage 1 or stage 5 if it's not mild, moderate, or severe, correct? Okay, so they will always document stage 1 or stage 5. However, for ESRD, end-stage renal disease, code N18.6. Both CKD and ESRD documented. You only need to code for your N18.6. Okay. Now, sir, both CKD and ESRD, like for example, CKD stage 5 and ESRD is documented. When you say end-stage renal disease, the guideline is you only need to code for ESRD or end stage renal disease, because guys, your end stage renal disease is obviously the end stage, or this is the highest, the severe one already. Okay, the highest stage or the most worst case scenario. Okay, so for this one, you only need to code, like for example, what if in the scenario they put in stage 5 CKD and in ESRD? So there are two types of two stages technically. So we will going to use your ESRD only because that is the end stage already. Now, how would you know if the patient already suffered an ESRD? Okay, this is a common question in the exam. If it's already an ESRD, the patient already required your dialysis. So that's why you also need to code when you use your N18.6. You always need to code your dependence on dialysis. Okay? So reminder with this guideline, if both CKD and ESRD are documented, assign only the code for N18.6. Okay. Chronic condition disease and kidney transplant status. Okay, guys, for patient who undergone kidney transplant, because these are common procedures, these are common successful procedures that you may encounter. Okay, so patient who have undergone kidney transplant may still have some form of CKD because the kidney transplant may not fully restore their kidney function. So guys, it's very important to put in, like for example, the patient has a CKD, post-transplant, post-kidney transplant, and the patient suffered still have your CKD stage 4, and if the patient may suffer CKD after a kidney transplant, that CKD is expected already because the kidney may not restore the full function yet. So it's very important to code in Z94.0 to fully identify what happened with the patient. Like the patient suffered CKD because it is a post-kidney transplant patient. So it doesn't require additional management because that is already expected. Correct? So it's very important to put in your status Z code, Z94.0. Chronic kidney disease with other conditions. Common example here is, like for example, you have your hypertension and your CKD, or even your diabetes with CKD. Guys, your sequencing will always be dependent on your tabular list instructions when you go through your tabular list codes. Okay? So that is your chapter 14. Okay, so we're done with chapter 13. We're done with your chapter 14. Now let's move on to your chapter 15. This is a quite long discussion, guys, but I'll do my best to discuss as fast as I can. But let me know. Put in your comment below if you have any questions regarding these chapters, because I love chapter 15. Pregnancy, childbirth, and the puerperium from 000 to 09A. Okay, before moving on to your discussion with your guideline, guys, please go ahead to your tabular list. Go to your O. Starts with letter O in your tabular list. You have the first page there that they will tell you all the instructions. All instructions. Because remember, every chapter or every part of your tabular list from A to Z, you will going to see a general instructions at the beginning of each tabular list. Okay. Now, it is very important for you guys to highlight those, because if you forget to do the guidelines at the beginning of your book or at the front page of your book, your first part of your tabular list will going to remind you about the guidelines. So let's start first with your trimester, which you can see there. Trimesters are defined as follows. First trimester is less than 14 weeks to 0 days, 0 to less than 14 weeks. For second trimester, 14 weeks up to 27 and 29 days. Okay, less than 28 days. And your third trimester is your 28 weeks up to your delivery. Okay? So my highlight there, anything below 14 is first, 14 to 20, below less than 28 is second, 28 and above is your third trimester. Okay. Now, why do you need to know this one, guys? You may write that in your book, or you may, you may just highlight your book there, or you may just memorize because it's quite easy. For mothers, yeah, they know, obviously they know this one. Now, you need to know the time frames of your trimester because these are very important in the code selection later on. Most of your codes in your chapter 15, you need to identify the final character or the trimester during the encounter. Okay? Next one, you also need to have your weeks of gestation. Guys, if the baby is still in the womb, you always need to code Z3A. Okay? A code from category Z3A will going to specify the weeks of gestation are in the use in the maternal record to indicate the specific week of gestation of the pregnancy. These are just an additional codes. It should always be coded at the last. Okay? Because this is important. Sir, what if there's no specification of your weeks of gestation? We have unspecified for this weeks of gestation. Okay? Don't worry, guys. Like, for example, if 11 weeks, that is Z3A.11. You may check your Z3A, guys, at the end. I don't know if what specific page, but you may go and check your Z3A. For example, if it's 12 weeks, Z3A.12, 13 weeks, Z3A.13. For 14 weeks, Z3A.14. Now, sir, I have a question about it. Like, for example, the patient came in 13 weeks and 3 days. So what should I choose? Z3A.13 or Z3A.14? Okay? Any answer there? Okay. 13 weeks and 3 days. The patient came in, the pregnant woman came in 13 weeks and 3 days. What should I going to use as Z3A? Z3A.13 or Z3A.14? Okay? Guys, the correct answer is Z3A.13. Why? You always need to count if it's already a full week count. Okay? You only need to count a week if it's 7 days already. Correct? If it's just 3 days, it's not considered 14 weeks yet. Okay? So still 13 weeks. Okay? Now, let's start with the general guideline or general rules for obstetric cases. Okay? Code from chapter 15 and sequencing priority. Okay, guys. When you ride a public bus or public transport, if it's a pregnant, it's always a priority. Even in a line or in a lane that you, okay, like for example, they're going to buy food in your fast food like that. If it's a pregnant woman, it should always be a priority because they are pregnant, correct? In all aspects, like in a public places, the pregnant woman should always be a priority. And in your coding, chapter 15 codes have sequencing priority in all other chapters. Okay, so it doesn't matter even if what chapter is that. You always need to know, okay, you always need to sequence first your pregnancy or your chapter 15. Additional codes from other chapters may be used in addition to your chapter 15. But you always need to make sure that your chapter 15 should always be your first listed code, except for this guideline. Pregnancy is incidental to the encounter. When you say pregnancy incidental to the encounter, like for example, the sexually active married woman came into the clinic with like UTI, urinary tract infections. Okay. Now, before a provider will going to prescribe any antibiotic for the UTI, for the urinary tract infections, the patient should always undergo a urinalysis or even a pregnancy, or to be specific, your pregnancy test. Okay, to make sure that the patient is not pregnant. So if, like for example, upon use during the pregnancy test, they incidentally found out that the patient is also pregnant. This is called your pregnancy incidental. Now, your first listed code should be your conditions that triggers the encounter or the reason why the patient came into the clinic, and you just need to add in your Z33.1. Now, remember, it's not yet an O code, so meaning it's a Z code, so it should not be a first listed code. Okay? Because it's accidentally, you just found out that the patient is pregnant. Okay? Chapter 15 codes is used to be used only on the maternal record because the baby has its own record as well and should be coded in your chapter 16 as we discuss after this video. Okay? For the next video that I will going to discuss, we will going to discuss chapter 16, and that's for the baby. For chapter 15, we will going to discuss about the mother only. Okay? The mother only, or the mother's record, because I cannot say that it's the mother only because there are some conditions here that the baby may be affected but still coded under your chapter 15. Okay, so but in your chapter 15, we are solely talking about the medical record of the mother, the maternal record. Okay, now final character for trimester. As I mentioned a while ago, that's why I discussed a while ago the time frames for trimesters, because final character or the last character of most codes in your majority codes in your chapter 15 is divided based on your trimester. Okay, the majority of codes in your chapter 15 have a final character indicating the trimester of your pregnancy. So the time frames from the trimester are indicated at the beginning of the chapter, so as I mentioned a while ago. Okay. Now, since codes are divided or based on the final character, which is your trimester, if the trimester is not a component of code, because there are, remember, it's majority, meaning there are also codes that don't have any, that will not going to specify the trimester. Not all, because it's the majority. Now, the reason for that is, it is because the condition always occur in a specific trimester. Or the concept of trimester of pregnancy is not applicable. Because certain codes have characters that only certain trimester, because the condition does not occur in all trimester, but it may occur in more than just one trimester. Like for example, in your chapter 1, your MS is hyperemesis gravidarum, your nausea and vomiting, that usually happen in your first trimester, correct? Correct me if I'm wrong. But that usually happen in your first trimester in pregnancy. So you no longer need to specify the trimester because it is expected already that it only happened in the first trimester. Correct? Now, for the second trimester, what I saw most of the time is your gestational diabetes. That always happens in your second trimester. It may happen also in the third trimester, but it always occur in your second trimester. And it doesn't happen in your first trimester. That's why it's very important, guys, for you to check your blood if it's already you are already on the second trimester, because you need to monitor that one, because you may suffer a gestational diabetes. Okay, in your chapter in your final character, okay, which is obvious, most of the time the patient may suffer already edema. Okay, because remember there are when the baby grow, okay, there are suppression of your blood flow that most of the time that might result into your edema. And your edema, it's common in your in your third trimester. Okay? Now, assignment of final character for trimester should be based on the provider's documentation of the trimester or the number of weeks. That's why we always need to know the number of weeks, because the provider usually put in the number of weeks. They will not going to specify if it's first, second, or third trimester. So you need to know that. This applies to the assignment of trimester for pre-existing conditions as well as those developed during or due to the pregnancy. The provider's documentation of number of weeks may be used to assign the appropriate code identifying the trimester, whether the delivery occurs during the current admission and there's an childbirth option of obstetric complication being coded. The childbirth code should be assigned. Okay. Now, this is a very important guideline. Selection of trimester for inpatient admission that encompassed more than one trimester. This is common, guys. Like, for example, the patient is admitted to the hospital in her first trimester. Okay? And the patient stays in the hospital up to her second trimester. At the time of discharge, she is already in her second trimester. Okay, so what should I going to use? Because during the admission, it is first trimester. But during the discharge, the patient's already in the second trimester. In instances when a patient is admitted to the hospital for complication of pregnancy during one trimester and remains in the hospital into a subsequent trimester, the trimester character for an antepartum complication code should always be assigned on the basis of, please highlight this, guys, trimester when the complication developed. Meaning, it should be your first trimester. Like in my example, it should be your first trimester because not the trimester at the time of discharge, because the complications being developed on the first trimester. Okay? So if the condition developed prior to the current admission or represent a pre-existing condition, okay, so the trimester character at the admission, of course, should be assigned because it's already pre-existing. It's not developed. Okay. Unspecified trimester, just like you don't need to use unspecified because this is very important. I mean, majority of your codes specify your final character. So why did they do that? Just to make sure that they are very specific with your codes. Now, if you're going to use unspecified, that will going invalidate all those purpose of codes. So, it's rarely being used, guys. You don't need to use this unspecified because as you see, most of the codes are divided based on the final character for trimester. Okay, so you rarely use this one. As much as possible, do not use this one, or always query the provider for certain specific trimester. Okay. Okay, next one, 7 character for fetus identification. Just put in, guys, your fetal extensions, what they usually term as fetal extension. But I usually put in your this guideline that this is applicable only for multiple gestations. Okay, this guideline is applicable only for multiple gestations. Like if the patient's having a pregnancy of twins, triplets, quadruplets, like that. Okay, anything that is more than one. Okay, it's a multiple gestation. Now, these fetal extensions is very important because sometimes if the condition is related to your baby 1, not the baby 2, I mean, just to identify the baby who's suffering some conditions. Okay? Oh, when you go to your O31, I have an example here. For O31, for fetus 1, fetus 2, as you can see, the 7 characters, that 1, 2, 3, 4, 5. If we're talking about fetus 1, basically they just put in is it the fetus 1 or fetus 2 is being affected, like that. So the provider should always document who is being affected by the condition. Now, sir, are we talking about the fetus, correct? Yeah. Why are we going to code the why are we going to use for the mother's side? Guys, because remember, the baby is still in the womb. As long as the baby is still in the womb, it should be coded under your O codes on the mother's side because the baby is not yet a separate one. It's still one. Okay? For single gestation, you need to use your 0, but the purpose of this fetal extension is just to identify what fetus is being affected by a certain condition. Because like there are certain conditions that, like for example, if a twins, the baby 1 is only affected and that not the baby 2. Okay, so sometimes you need to, sir, how would I know who's being affected? Always, they will going to document who's the baby 1 and baby 2 there. Okay, because the provider should always know who is baby 1 and who is baby 2. Okay. This one, next guideline, selection of OB, principal or first listed diagnosis. Guys, in the exam, definitely they will going to ask about principal or first listed diagnosis because in your CPC exam, they will always going to test you how well versed are you in the sequencing of your ICD10CM codes. Okay, let's start with the first one. Routine outpatient prenatal visits. Because remember, guys, if the pregnant woman is if it's a pregnant woman, it is a mandatory that you always need to visit for your prenatal. Okay, you always need to go through your doctor, through your OB/GYN, for your normal routine visits. For routine outpatient prenatal visits with no complications are present, a code from category Z34 and counter for supervision of normal pregnancy should be used as the first listed code. Put a note there or highlight that one. Z34 is always the first listed code. Okay? And you only need to use Z34 if it's a normal pregnancy and no complication at all. Just like it is your normal scheduled visit. Okay. Now, this is very important, guys. What is your number of your scheduled prenatal visit? Okay. Like, for example, in the first trimester, how many times should you visit your OB/GYN? Okay. What is the normal prenatal visit during your first trimester? Okay. Put a note there. For first trimester, your normal visit should be monthly, correct? Once a month. Okay? Correct. That's a normal scheduled visit if it's your first trimester. Now, for second trimester, what is your normal routine visit number? Okay? That should be twice a month or every second week. That is for your second trimester. For third trimester, how many times should you visit your provider or your OB/GYN? Okay? It is weekly. Okay? If you are already on your last trimester, you are going to visit your OB/GYN weekly for third trimester. Now, your Z34 should not be coded in any O codes. Okay? When you use your Z34, because guys, when you use the O codes, meaning there's a complication, there's a problem. When you use the Z codes, it's a normal thing. That you need to take note of that. Every time you use the O codes, there's a problem with the pregnancy. Okay? For this one, we are talking about only Z34. That's why the guideline reminds you not to code with any conjunction from O codes because it's just a normal. Now, what if you exceeded the normal visit? Okay? The normal required visit during a specific trimester. If you exceeded the normal visits during your certain trimester, meaning there's something wrong. Meaning that put you into the next guideline, high risk pregnancy. Okay? Because if it's a normal pregnancy, they will your OB/GYN will tell you to just put in your normal visit, to visit us in your normal scheduled visit. Now, if you exceeded, you may be considered a high-risk pregnant patient. And the category for that is O09. But remember a while ago, when you are high risk already, you are no longer considered normal pregnant patient. So remember, your Z34 can never be coded with your O09. Okay, your O09 as well should always be a primary or first listed code. Okay, code from category O09, supervision of high-risk pregnancy, are intended to use only during the prenatal period, and these cannot be used with your Z34. For complications during the labor and delivery as a result of a high-risk pregnancy, assign the applicable complication code for your chapter 15. If there are no complications, you have your OAT and counter for full-term uncomplicated delivery. just keep in mind other conditions, guys, that you may be considered a high risk pregnant. If you already have preeclampsia or there's an hypertension induced pregnancy, or you may have your diabetes, gestational diabetes. There are other, or you have a history of any high risk pregnancies. You are considered high risk already. Okay. For routine prenatal outpatient visits for patients with high-risk pregnancies, a code from category O09 should always be a first listed code. As I mentioned a while ago, it should always be a first listed. And secondary chapter 15 codes may be used in conjunction to those if it's appropriate. Yes, you may still need to code and use an additional codes as long as your O code should always be your first listed code. Okay. Episodes when no delivery occurs. In episodes when no delivery occurs, the principal diagnosis should always be the pregnancy which necessitated the encounter. If no delivery, when delivery occurs, the first listed code should always be the prompted admission should be sequenced as the principal diagnosis. Okay, outcome of the delivery. When we are talking about outcome of the delivery, okay, we're talking about, is it single, twins, triplets, like that, or is it live, or is it dead? Okay, because there is stillbirth. You have your live birth and you have your stillbirth, and the difference is also if it's single or multiple outcome of the delivery. Okay, a code from category Z37 outcome of delivery should be included in every maternal record. So this should be in the maternal record when a delivery has occurred. These conditions are not to be used in subsequent encounter or newborn record. Guys, your Z37 is for reporting purposes. Okay, that the mothers delivered the baby in our hospital or in our facility. Okay, so since these are just supporting details, meaning just information about it, your Z37 should always be an additional code only. It's not it should never be a primary code. It's just an additional code at the end to specify that the mother delivered in our facility. And it should not be used in subsequent records. Like, for example, the patient transferred to the hospital or go to a different clinic like that, or lying in clinic. It's a different thing. You no longer need to code for the Z37 because you only need to code this one once. Okay? Okay. So example, when you go to your Z37, you can see there single live birth, single stillbirth. You have your twins, one live birth, one stillbirth, like that. You can send options about that. Pre-existing conditions versus conditions due to the pregnancy. So as you can see, there are conditions like you may have a hypertension already before you get pregnant, but there are some patients also suffered hypertension due to the pregnancy. There are also patients that they already have a diabetes before they get pregnant, and there are also patients that they suffered a gestational diabetes due to the pregnancy. Okay? Certain categories in your chapter 15 distinguish between a condition of mother that existed prior to the pregnancy or pre-existing and those who direct result of the pregnancy. It's very important, guys, because the management is really different. Because if you already have a condition, meaning you already have an existing management as well, rather than if it's a condition induced due to the pregnancy, so that's a new management that they're going to implement. Okay, so when assigning codes from your chapter 15, it's very important to assess if a condition was pre-existing prior to the pregnancy or developed during the pregnancy in order to assign the correct code. Okay, it's very important. Categories that do not distinguish between pre-existing or pregnancy-related condition may be used for either. Okay, so it's acceptable to use codes specifically for puerperium with codes complicating pregnancy and childbirth if a condition arises postpartum during the delivery encounter. Now, you have your pre-existing hypertension in pregnancy. This is a common condition that may suffer, also known as your preeclampsia. No. This one, preeclampsia, is your hypertension due to the pregnancy. For this one, the patient already have an existing hypertension. The guideline with your hypertension is still the same in your chapter 9, just that you need to add 010 first in your first listed code. Put a note there. 010 should always be a first listed code if the patient has a pre-existing hypertension before the patient get pregnant. Okay, so pre-existing hypertension complicating pregnancy, childbirth, and puerperium includes code for hypertensive heart and hypertensive chronic kidney disease. When assigning one of the O10 codes that includes hypertensive heart disease or hypertensive chronic kidney disease, it is necessary to add a secondary code for the appropriate hypertension like your I11, I12, like that, or I13. The guideline for your chapter 9 is still the same. It's just that you need to code your O10 first because we're talking about pregnant woman. Okay, so I'm not going to elaborate more on this because I already discussed chapter 9. You just need to add O10 because we are talking about the pregnant and to justify that O code should always be the first listed. Correct? Okay, this is the purpose. Fetal conditions affecting the management of the mother. Now, we're talking about the fetus here. We're talking about the fetal condition. However, if the fetus is being affected, if there's a problem with the fetus, who will you going to ultrasound? Diba? Right? So it's still the mother. Okay? So it affects the management of the mother. So that's still considered your O codes. So you have your codes from O35 and O36. A code from category O35, maternal care for known or suspected fetal abnormality and damage. O36, for any other fetal problems. The problem here is like the fetus is the concern here is the fetus. The fetus may suffer abnormality and damages, but it is still coded under your O35 and O36 because the management should always be done to the mother, still to the mother. Now, the rationale here, the bottom line here, as I mentioned a while ago, as long as the baby is still in the womb, it should always be coded to O, even if the fetus is the problem. Because your management should always affect the mother. Okay? Because you cannot manage the baby without affecting the mother. Right? So it's still considered O codes. We're still talking about the maternal record. In utero surgery, guys, meaning this is there's a surgery being done inside the uterus. Okay, so the baby is still in the uterus, but they're going to have a surgery. So it's still it's considered, who will you going to, to perform the surgery? Even if it's in the baby, you still need to cut the mother, correct? So it's still managed. It still affect the management of the mother. So it's still coded as your O35. Okay, in utero surgery. Now, I'm not sure why they are performing any surgery inside the uterus, but based on my reading, this might be done if it's like the fetus have any conditions that may be cured or may be corrected with a surgery before the baby fully develop. Okay, so it might help the baby or the fetus so that when the baby already fully developed, it may go back to normal. If there's some problems with the fetus. Okay. HIV infection in pregnancy, childbirth, and the puerperium. Your guideline with HIV infection in your pregnant woman, it is still the same with the guideline in your chapter 1 about your HIV. It's just that you need to add your 098.7. During a pregnancy, a childbirth, or puerperium, patient admitted because of an HIV-related illness should receive a principal diagnosis of 098.7. When we are talking about pregnant woman which an HIV or AIDS or asymptomatic HIV, you always need to code 098.7 first. Okay? You always need to put in your sequencing there. Now, there is a dash because you always need to specify the specific trimester first. Okay? And you have your B20 if it's AIDS already, and HIV-related illness if it's available. Correct? That is your sequencing for your HIV-related illness. Your patient with AIDS. Now, if the patient is asymptomatic, but it is a pregnant, the patient is specific with positive with HIV. Okay, a pregnant woman is HIV positive, but there's no signs and symptoms yet. You need to code your Z21. But you always need to code first 098.7, followed by your Z21 asymptomatic HIV. Okay, next, letter G, diabetes mellitus in pregnancy. I know in the guideline there's no word like pre-existing. Just put in pre-existing there, meaning the diabetes is already present before the pregnancy. So in this case, your sequencing should be O24.1, .2, and .3. to be specific. And you always need to code the diabetes code and Z79.4 if there's a long-term use of insulin. Okay, diabetes mellitus is a significant complication factor in pregnancy. Pregnant women who are diabetic should be assigned a code from category O24, followed by your code E08 to E13, or your normal diabetes codes. You have your usual diabetic code from E08, E09, E10, E12, and your E13. Okay, you just need to put in your O24 because the patient is pregnant. Correct? And there is your diabetes mellitus. Okay? Long-term use of insulin, I already discussed that one in your chapter 4. Next, gestational diabetes. Now, when you say gestational diabetes, it's pregnancy-induced diabetes, meaning the patient suffered a diabetes due to the pregnancy. So, gestational pregnancy-induced diabetes, when they say gestational, it's obviously pregnancy-induced. Okay? Occur in the second and third trimester of pregnancy in women who are not diabetic prior to the pregnancy. So meaning that only happens because of the pregnancy. Gestational diabetes can cause complication in a pregnancy similar to those of pre-existing diabetes mellitus. It also puts the woman at a greater risk of developing diabetes after the pregnancy. Yeah, if the patient suffered your gestational diabetes, it's very important to monitor, guys, your condition, because this might develop. I mean, you might develop diabetes already. Okay, so codes for gestational diabetes on subcategory O24.4. Keep in mind, put a note there. I always put in the word code O24.4 right beside gestational diabetes. Okay, guys, if you see in the scenario that is a gestational diabetes, your first code should always be O24.4 and no other codes. Okay? If you see like O24.1, O24.2, that's not the code. It should be O24.4 always. Okay? An abnormal glucose intolerance is different with your gestational diabetes because you have your O99.81 for your abnormal glucose complicating pregnancy. When you say abnormal glucose tolerance, it's just the uptake of glucose. For gestational diabetes, we are talking about the number, okay, of glucose in the blood. Okay. Sepsis and septic shock complicating abortion, pregnancy, childbirth, and puerperium. Guys, your guideline is still the same with your chapter 1. It's just that you need to code your O code first because we have your puerperal sepsis, just to be specific. Here's the sequencing. You no longer need to use A41.9 and A40. You no longer need to use those one because we are not talking about severe sepsis due to microorganism, due to specific infection. Because that should only be in your chapter 15, it's still we're talking about organism, but since we're talking about pregnancy, your A41.9 is being replaced by O. Okay, like your O10, it's being replaced by your I10 is being replaced by O10 when we're talking about pregnancy. Okay, in this case, we no longer need to use A41.9 or A40 because it's being replaced by O sepsis code. Okay, so we have this an example. We have your puerperal sepsis. This is what I'm talking about. Puerperal sepsis. Should be assigned a secondary code to identify the organism. Okay, and a code from category A40 streptococcal or A41 other sepsis should not be used for puerperal sepsis. So as I mentioned, your O85 is already a replacement of your A40 and A41. It's just being used in your chapter 1. In your chapter 15, O85 should be your first code because we're talking about puerperal sepsis. Organism, if it's available already. R65.2 if there is a severe sepsis. If no severe sepsis, your code should always be up to this, an organism. If there's no organism, your code should only be O85. Now, if it's followed by severe sepsis, you need to add R65.2. And remember, if there's a severe sepsis, there should always be an organ dysfunction. Okay? That is your guideline number 1. Okay. Alcohol, tobacco, and drug use during pregnancy, childbirth, and puerperium. Guys, my reminder here, if the mother is still using an alcohol during the pregnancy, your code is O99.31. And you need to have your code for your alcohol use, dependence, or abuse. Okay, guys, we should not tolerate this one, because if you're pregnant, you should not be drinking, any alcohol at all, because no, it's very risky for the baby. I should inform that. I mean, you should know that. Okay, for tobacco, for certain reason, there are certain patients they can't stop having using the tobacco, okay, or smoking. O99.33 and F17 if the patient is still, you know, smoking. Okay. Um, I don't know, for God's sake, why are you using a drug if you're pregnant? You know, for pregnant woman who's still using drugs, okay, illegal drugs, just to specific, okay, just be O99.32, followed by F11 to F 16, sorry for that, and F18 to F19. Okay, those are your codes. Poisoning, toxic effects, adverse effects, and underdosing. This is we're talking about your prescribed medications, like a code from category A9A.2, injury, poisoning, and certain other consequences of external causes complicating pregnancy, childbirth, and puerperium should be sequenced first. Guys, if there's a toxic effects, poisoning, or adverse effect during a pregnancy, underdosing during a pregnancy, it doesn't matter if it's poisoning, toxic effect, adverse effect, or underdosing. Your first code should always be O9A.2. What matters now, if it's poisoning, toxic effects, or adverse effect, or underdosing, is the second and the third code. If it's poisoning, guys, remember your guideline for poisoning, code the poisoning code first, followed by the condition. But for adverse effect, you need to code first the condition, followed by the adverse effect. I will further discuss about poisoning, toxic effect, adverse effects, and underdosing as we discuss your chapter 19. But I already discussed this one in your in your tabular list. Okay, when I discuss about your table of drugs. Okay, I just already give you a hint what should be your sequencing. Normal delivery code is O80, and counter for full term uncomplicated pregnancy should always be coded O80. Guys, when you say and full term uncomplicated, there's no problem at all. The mother delivers a single baby and it's healthy and no other complication at all. And it should always be a first listed code, O80. Okay? Now, when you use your O80, you always need to code as well your Z37, which I'm going to discuss later on. Uncomplicated delivery with resolve and depart. Even if the patient has a complication before the delivery, but during the delivery, there's no complication at all, you still need to code a O80. This is what the guideline tells you. Code A80 may be used if the patient had a complication at some point during the pregnancy, but the complication is not present at the admission of the delivery. Because that might happen. Correct? This is what I'm talking about. O80. When you use your O80, you always need to code Z37.0 as well. Because single live birth is the only outcome of your delivery for appropriate to use for O80. Because when you say O80, the mother delivered a single live birth baby. I'm not saying that it's abnormal to have twins. No, but as per your guideline, you can only use O80 if it's a single live birth and there's no complication at all. Okay? Peripartum and postpartum periods. When you say postpartum, it begins right immediately after delivery and up to 6 weeks. For peripartum, the last month up to your 5 months of postpartum. Okay? Postpartum complications is only complication occurring within the 6 weeks period. Now, if it's Now, this is a very common guideline in the exam. Like, for example, the mother came back for follow-up after 4 weeks after delivery. 4 weeks after delivery. Can you still use the O codes? Yes. Guys, as long as the condition is still related to the pregnancy, within the 6 weeks, you still need to code the O. Because sometimes, for example, the patient came into the clinic with hypertension, and the hypertension is associated to the pregnancy. What should you going to use? If it's 4 weeks after the delivery, the patient came in for hypertension, and you know that the hypertension is related to the pregnancy, what should you going to use? Is it your I10 or O10? Guys, a lot of students is having a mistake with this. If it's still on the 6 weeks time frame of your postpartum period, you always need to use first the O codes rather than the I codes. Okay? Guys, just to make sure, you always need to see a documentation that the condition is still pregnancy related. Okay? Pregnancy related after complication after 6 weeks. Now, sir, what if it's already more than 6 weeks? Even if it's already more than 6 weeks, if there is a documentation that the condition is still related to the pregnancy, you still need to code the O. Okay? Number 4, admission for routine postpartum care following delivery outside the hospital. Like, for example, the mother delivery in the car before hitting the hospital, or it delivers in the plane before heading to the hospital. Okay, the mother delivered already in the car or anywhere in the public transport, in a train, like that. So when the mother delivers outside the hospital prior to the admission and it's admitted for routine postpartum care and no complications are noted, your code should always be Z39.0. Encounter for care and examination of mother immediately after delivery and should be assigned as principal diagnosis. Okay? You can no longer use for the code for the delivery because the baby's being delivered already. So you no longer need to code. The hospital should no longer report for delivery because the baby was being delivered already outside the hospital. Now I have a student asked me before, sir, the definition of delivery, meaning delivery of all products of conception. Okay, meaning your placenta. Okay, so the placenta might still be there. So the definition of delivery is not being completed yet. Okay, now remember, encounter for care and examination of the mother immediately after delivery. Your placenta delivery, your cut of your cord is already included here. Okay? The basis for coding delivery should always be the baby, if it's being delivered or delivered already. Okay? Pregnancy-associated cardiomyopathy. When you use your index, guys, you need to use the peripartum. I think pregnancy first and then peripartum. Cannot find this one in your index without using that. You cannot go ahead in cardiomyopathy. Now, pregnancy-associated cardiomyopathy code 090.3 is a unique in that it may be diagnosed in the 3rd trimester of pregnancy but may continue. Guys, remember, if you have the baby's growing, remember, if the baby is growing, all of the body organs of the mother are also increasing the task, the job. Like the heart need to increase his job, the lungs, all of her internal organs need to adjust because there are two. The baby and the mother. Now, some mother may suffer pregnancy-induced cardiomyopathy or pregnancy-associated cardiomyopathy, so 090.3. Now, for this reason, it's referred to as peripartum cardiomyopathy. Code 090.3 is only used when the cardiomyopathy develops as a result of pregnancy in a woman who did not have any pre-existing heart disease. Okay? 094, sequela of complication, pregnancy, childbirth, and puerperium. 094. For some reason, you cannot code 094 as the first listed because the guideline for sequela is you need to code the condition first followed by 094. Okay? Code 094 sequela of complication of pregnancy, childbirth, and puerperium is for use in those cases when an initial complication of a pregnancy develops. A sequela require care for treatment on the future date. Common example, for example, you have your stretch marks and your 094 is a sequela or complication of pregnancy. Okay? Sequencing should be the condition first, followed by the sequela. Okay? Now, this breaks the guideline that O code should be the first listed. Because remember your guideline for sequela, you need to code the condition first, followed by your 094. Okay? After initial and postpartum period, you can now use your 094. Sequencing of 094, this code like sequela is to be sequenced followed by the code describing the sequela of your complication. Termination of pregnancy and spontaneous abortion. Abortion with live-born fetus. Like, for example, the mother attempted to terminate the pregnancy, but that termination of pregnancy resulted into live-born fetus. Oh my goodness. Okay. So for some reason, if it's attempted pregnancy and the result is a live-born fetus, so the fetus is very lucky enough. Z33.2 followed by your Z37. Now guys, make sure that you can only use your Z33.2 if it's being documented that it is the mother attempted to terminate the pregnancy. It should be specific in the medical record that the mother attempted to terminate the pregnancy, because for some countries this is illegal, but for other countries it's legal, so it might have a legal issues, okay, in your medical record. Okay. Retained product of conception following an abortion, O03.4, incomplete spontaneous abortion without complication. Now, there are certain, there are cases like, because sometimes if it's really incomplete, it always results to complication. But there are cases like there's an incomplete spontaneous abortion, but there's no complication at all. That's why they added this code, because there are cases like that. But most of the time we assume that if there's an incomplete, if there's a remaining product of conception inside, that should always result to a complication. But for some reason, there are cases like even if there is a remaining product of conception, there's no complication at all. So we have your O03.4, because you always need to base your coding on the time of encounter. Okay, it might not develop, the complication might not develop yet. It might develop after a week or 2 weeks, right? So if the patient has a specific complication associated with a spontaneous abortion or elective termination of pregnancy, in addition for retained products of conception, we have a separate code for that, and that is your O03 and O07 instead of your O03.4 or your O07.4. Okay? Complications leading to abortion. Code from Chapter 15 may be used as additional code to identify any documented complication of pregnancy in conjunction with the codes in subcategories O04, O07, and O08. Okay? I think this is the last one. Abuse in a pregnant patient. Okay? Why with the word should this be happening? Why should you abuse a pregnant patient? Remember, they are pregnant. Why should you abuse them? But there are, for some reason it happens as well. So abuse in pregnant patient is coded with the following subcategories. You have your 098.3, physical abuse. 098.4, why with the word this should have a sexual abuse. 098.5, psychological abuse. I think psychological abuse is common. Okay? Especially if your husband's no longer, there are some cases like that. So, physical abuse, sexual abuse, and psychological abuse. Now, keep in mind that I will be discussing, I think, another chapter 19. Still in chapter 19. We're talking about abuse. Guys, you can only report abuse if it's confirmed abuse. So, that's why the sequencing is 098.3, 098.4, 098.5. Guys, if all abuses happen, if all abuses is being present, you need to code them all, and the sequencing is like this: 0.3, 0.4, and 0.5. But if it's only like physical abuse, you just need to put in 098.3. If it's only a psychological abuse, you may going to use 098.5 only. Now, remember, abuse may result to an injury. If there's an injury coded as your injury code, and you have your perpetrator, meaning you're a perpetrator, who abused you. Okay? We have a code for, like, for example, if it's the husband, like that. You need to code for that, for the perpetrator. Okay? I think that ends your chapter 15. Now, on the next video that I will going to discuss, your chapter 16, 17, and 18, and I'll try to tackle 19 already. Just to make sure that we're almost done, because 19, 20, and 21, we are only left with 16, 17, 18, 19, 20, 21. 6 chapters already that I can discuss in 2 videos. Okay? So that we can proceed with your CPT. Guys, if you're new to my channel, don't forget to hit the subscribe button. Share this video if it's very helpful with you. And guys, thank you for those wonderful feedback that I'm receiving through my email, to my comments, and to my Facebook chats. Thank you so much and happy coding and good luck in your study.